I'd like to welcome you to the Head and Neck Society Endocrine Section, British Association of Endocrine and Thyroid Surgeons inaugural joint webinar on parathyroid and thyroid surgery. And want to very much welcome you for the happy holiday seasons. I think we're all pretty much ready to kiss 2020 goodbye, and we welcome 2021. And we hope also, I want to emphasize the inaugural nature of this webinar. Neil will talk about a couple of endeavors that we've worked on together, our two societies, and so we hope that this is the beginning of numerous programs that we will be working on together. So today's program, we will have Neil Tully and I will moderate. We'll have three cases, about 15 minutes each. Fiona Etok, Sherry Ann Nathan, and Fausto Palazzo will be presenting the cases, and the discussants, that is, the people that would be providing the definitive answers and advice, will be Dr. Brendan Stack and David Scott Coombs. I wanted to just briefly introduce the Head and Neck Society. This is the largest organization in North America for the advancement of research and education in head and neck oncology. About 1,700 members, both general surgeons and otolaryngologists, about 600 members of the endocrine surgery section. There are multiple benefits of membership, and the ability to join our membership is on that online reference. Neil, maybe you could introduce the British Society.
Yes, and it's a great privilege and a pleasure to join our societies for this meeting. We're bonded by history and language, and one of the good things that have come out of the pandemic is that it's enabled us to have opportunities of collaborating more and doing online learning. Our association was founded in the early 1980s, and it was quite an important time in the development of societies for endocrine surgeries, because around about that time, the International Association of Endocrine and Thyroid Surgeons was also formed, as well as the American Association of Thyroid Surgery. It's multidisciplinary, we're proud of that, with members from a general surgery and an otolaryngology background. We have just over 300 members. And we're very proud in particular of our national mandated registry for thyroid surgery, which we have over 130,000 operations represented on that. It is the UK representative body for thyroid surgery, and we have an annual meeting, we have an executive, and our remit really is to compile various guideline consensus documents, and I'm particularly proud that our societies have come together to work on a number of projects that have come to fruition. The first one was a guideline consensus on revision parathyroid surgery, and Brendan spearheaded that. We're very much focused on education, research and training also. We have an executive structure. And the American Head and Neck Society, the endocrine section with Brendan Stack and Michael Singer, they're both representatives of your association on our executive meeting. We're running a little bit late, so I think it's important that we get on now with the actual webinar.
I'll go back to just mention that we will be available this webinar that Betty will be sending us to obtain that evaluation and CME disclosure slide we need to provide here so that you see all of our faculty's disclosure. And again, I want to now have Neil introduce our first case, which Dr. Fiona Etok will present, dilemmas in treating PTC in our first COVID wave. So with that, Fiona, I will, Neil can introduce you, and I will stop sharing my screen so you can share your screen.
So it's a great pleasure to introduce Fiona, who's a colleague of mine on the BAETS executive. She's our treasurer. She's an endocrine surgeon that works in Belfast and therefore comes from a general surgical background. And she's going to be giving the first talk. So Fiona, thank you very much. You're on mute, Fiona.
Okay. Good afternoon or good morning to our friends in the US. Thank you to Neil and Greg for all their hard work in bringing today to fruition, and also to Betty for all of her support. And first of all, I have no conflicts of interest to declare, and I'll get on and present this case. So back in May of this year, in the midst of the national lockdown in the UK, 34-year-old man presented with a 3-month history of hoarseness. He was otherwise entirely well, had no other symptoms. He had no past history, was not on any medication, and had no personal history of radiation exposure or family history of any thyroid or other endocrine tumour. Examination revealed a left-sided solitary nodule in his thyroid, but there was no lymphadenopathy palpable in his neck. Thyroid function tests were entirely normal. So we proceeded to ultrasound of his neck, and this revealed a 3.7 centimetre solitary nodule in the left lobe, and as you can see, large nodule with irregular margin, microcalcifications. There was evidence of central flow on Doppler settings, and possibly even some evidence of breach of the thyroid capsule posteriorly. Radiologist graded it as a BTA-U5 or TIRAD 6. Fine needle aspiration was undertaken, and this showed a very cellular aspirate with nuclear features of a papillary thyroid carcinoma, and that was graded BTA Thy5 or Bethesda 6. With those appearances, we proceeded to a contrast CT of neck and chest, which again confirmed the left thyroid nodule with no lymphadenopathy or any other abnormality. So David and Brendan, what now?
Well, this is a great case and great imaging. And did you mention what the sizes were? I might have missed that in your presentation.
3.7 centimeters on ultrasound. Okay,
3.7. So obviously, we need to start having a discussion with the patient as to what their options are. Of course, I will refer to the ATA guidelines because that's sort of the environment that I live in. But 4 centimeters seems to be a measurement of significance as to whether we are going to opt for a hemithyroid or a total thyroidectomy. And so I would have a blended discussion with those options. I mean, technically by those measurements, you might be able to get away with a hemithyroidectomy, but there might be concerns about not doing a total, especially not being able to use radioactive iodine. And I would discuss the differences between the two operations as far as a potential complication profile.
Would you have...
Sorry, Fiona.
Go ahead, David.
Probably due to time, you skated over the clinical examination, and I haven't heard anything about whether there were palpable lymph nodes, and I haven't heard anything about lymph
solid
nodes.
nodule in the thyroid with no lymphadenopathy palpable.
Okay, and are there any ultrasonographic evidence of lymph node metastases laterally?
No.
And then you did mention hoarseness of the voice. So
yes.
First of all, did he sound hoarse? And have we done indirect laryngoscopy?
So yes, he sounded hoarse, hoarse, breathy voice. And he presented at a time when we were very cautious about direct laryngoscopy because of COVID. It was in the height of the first lockdown.
So it wasn't done.
Can I just ask the discussants and Fiona, this patient's got a vocal cord palsy, let's just assume that. Would that alter your management plan for this patient?
So yes, I think it definitely does alter the management plan. As Brendan said, 37 millimeters is in the grey area for some people as to whether to do a hemithyroidectomy or a total thyroidectomy. The man is young, 37, so that's a favourable prognostic factor, but he's got what sounds like local invasion or assumed local invasion due to the hoarseness of the voice and the suspicious nature of thyroid capsular invasion on the ultrasound. The CT scan, I presume, was to confirm that there was no evidence of gross tracheal involvement. But this is a man with local invasion. He's got poorer prognostic disease. In my head, I can't calculate MACIS, but it'll be, north of 6. So I think that he should definitely be a candidate for a total thyroidectomy. Of course, there is then the consent issues over the risk to injury to the contralateral recurrent laryngeal nerve and the risk of tracheostomy, which must be part of the consent process, or at least a factor there. Now with COVID, you might take the view to dissect the abnormal side first, and if the nerve cannot be preserved or has to be sacrificed, you might take a view as to whether or not to do a staged total thyroidectomy if you are yourself worrying about a risk of tracheostomy. Personally, I would go for a total thyroidectomy.
Yeah, can I ask, Brent, we don't really have access at the moment to molecular profiling of tumours pre-surgery. You do, you have panels. Would you molecular profile this patient before deciding what the treatment, in view of the fact we're in the middle of a pandemic and ITU beds are scarce?
I wouldn't molecular profile this patient even if we weren't in a pandemic. I think the molecular profile is largely going to be reserved for Bethesda 3 and Bethesda 4. And this case, I think, is clearly malignant. And so I don't think you should spend any time or money with molecular profiling in this case.
There is a question from the chat, actually, Radu Mihail, hi Radu, about if the nerve is involved, and David, you mentioned this, then viscera might be involved. So Radu said, anybody want to get a contrast enhanced CAT scan to look at the esophagus and trachea in this patient who has a cord out?
But normally we avoid contrast CT because of the potential stunning effect of subsequent radioiodine therapy. A CT scan without contrast, I don't think is of any great value. But the one time I think we would consider doing contrast CT is if we were worrying about aerodigestive local invasion, as one might be in this case.
So I would like to respectfully demur a little bit from David's point. We have a very low threshold for contrasted CTs. If you think about the time course between the preoperative contrasted CT, the time to going to surgery, postoperative recovery, and then the time that we're starting to talk about radioactive iodine, it's very common that 2 months has passed. And so any saturation would have resolved. But if there was a concern about that, you can always do a urine collection for iodine to see that the patient no longer is iodine saturated. So we largely don't let that fear of using contrast affect us in not ordering a contrasted CT.
So Fiona, we want you to go ahead with the case now, but as you do so, as you talk about what procedure you would be doing, there was a case, Ahmet Akiz, it has asked, would you consider doing, what are you thinking about a central neck dissection as part of your procedure? But then please go ahead with the rest of the case.
Thank you. Well, we proceeded to surgery. This was back in May, in the peak of the epidemic. We found that the recurrent laryngeal nerve was encased with tumour, but there were no obviously involved nodes at the time of surgery in the central compartment. And so we proceeded to a left lobectomy with sacrifice of the recurrent laryngeal nerve because we couldn't clear the tumour without doing that. But that resulted in a macroscopic complete resection. So the next lot of questions really are around the intraoperative decision making. So having explored the left side of the neck where the tumour is first, where do we go next? What should we do?
So there are some guidelines relating to this and management algorithms in the setting of an invaded nerve. And so a lot of that relates to discussion with endocrinology and the patient as to the risk that David mentioned about tracheotomy. Brendan and David, what do you think? How would you discuss that, and how would that impact on your surgical strategy?
David, you
One
want to
nerve
lead
is
off?
done. One nerve is done to begin with. So now you're going in, either you dissect the opposite side or you don't.
Well, that's exactly correct. And so then the discussion is with the patient about the risk of injury to the right side of the contralateral nerve from what one is assuming is a resection of a grossly normal thyroid. If there is either a temporary or permanent injury with the other nerve gone, there is a risk of a tracheostomy. But the risk is low. Everyone should know their own risks, and that is a conversation that will take place between the patient and the surgeon. So for me, I would go ahead and perform, with the patient's consent, resection of the other side. The only hesitation in my voice at the moment is when we're talking about a COVID era, and a tracheostomy in a COVID era on ITU would be an additional risk, and the patient and I may not wish to go there.
I fully concur, David. I think we all want to avoid a tracheotomy at all. That's just another order of complexity and impact on the patient. Thyroid ectomy for the cancer might be appropriate. We're sort of a little compromised because if we had intact nerves on both sides and we were doing intraoperative nerve monitoring, we could make our intraoperative decisions based on loss of signal. But we don't have that luxury in this case. We would just have to decide after we did the disease affected side, are things going well? Are the hollow viscus is not invaded and I just go ahead and do the completion? Ideally, I think this patient would be best served by a total thyroidectomy and post-operative radioiodine. But to David's point, I mean, this is a much more complicated scenario because we're in a pandemic.
Fiona, do you want to complete the presentation just to move things on?
Okay. So what we undertook was a left lobectomy, and we stopped. We didn't take the nodes because there was no obvious evidence either radiologically or intraoperatively of involvement, and so we didn't do a neck dissection, a central neck dissection. Pathology confirmed a 3.4 centimetre classical papillary thyroid carcinoma. There was one focus of possible but not definite vascular invasion, and it was staged at PT3B, N0 and M0, so stage 1. So what should we do now?
Well, I think at this point, the patient needs to be educated about the pathology and the need for ongoing surveillance. The fact that we might have done something different in different circumstances, that they have an understanding, and that hopefully will compel them to be more compliant with longitudinal follow-up at this point.
And can I ask you, going back to the molecular genetics, if we profiled the molecular characteristics of this tumour and it was TERT positive, would that influence your decision making now as to what the next stage of the patient's treatment would be?
So that is an excellent question. And so we have an opportunity preoperatively with the fine needle aspiration to do the molecular profiling, but we could also do it on the pathology specimen. So now we have a pathology specimen, we have something to work with, and we can get additional data. And whereas we've already decided, in effect, to stage this operation because we've only done a hemithyroidectomy at this point, if it was TERT positive, then maybe the discussion would go from we need to commit you to longitudinal observation to we need to plan in the next couple of weeks or months, depending on what's going on with the pandemic, with their recovery, etc., to do a completion operation.
The question from Michael Setchman from Cardiff. What do you feel about re-innovation at the time of surgery for this patient? Is that something you would do?
Is that a question to me or David?
It's a question to all three of you.
Okay. I would try it if possible, but it's not always possible. But I'd at least give it some consideration.
Segmental resection is sometimes problematic. I mean, with transection, you have ability to reanastomose, but with a segmental defect, I would think about ANSA perhaps. I would say oncologic removal of all the tumor, which Fiona emphasized she obtained, is the most important parameter. Dynamic reinnervation would be a second order importance in my judgment. But if you could get a negative distal margin and swing an ANSA, that would be very reasonable. Should we go ahead and move on to the next case?
Can I just ask one final question to all of you? In terms of the TNN classification, this is a T4A tumour because there's invasion of the recurrent laryngeal nerve. The difference between a T3B and a T4A is a moot point. Is there any evidence that invasion of the recurrent laryngeal nerve alone is a poor prognostic indicator compared to a T3B? And should therefore recurrent laryngeal nerve invasion alone perhaps not be classified as T4A? Should we question that?
So I'll go first. I'm a huge fan of MESIS, and obviously it was designed for papillary thyroid cancer. This C, as you know, is completeness of resection. It's the most important thing. I don't think that the nuance of 3B and 4A really objectively matters for this patient, but I would agree with you. I think recurrent laryngeal nerve invasion alone could be 3B.
I like your point, Neil. I think it's sophisticated, but I would agree with David. I'm not sure in this patient it's going to make a big difference.
I would take the opposite argument that the data does not support nerve invasion is prognostically significant. And this obscures and perverts the whole discussion of nerve resection as whether it helps prognostically or not. It's a very important piece of anatomy to try and preserve, and its resection does not improve prognosis because its involvement is not prognostically important. It is a functional dynamic, no question. But I agree with you, Neil. I think the AJCC, the staging is incorrect and does not take that into account, and we'll actually be publishing on that very soon. I wonder, should we move on with our next presentation, Neil?
I think so. Thank you very much, Fiona. We could have a whole hour at least talking about your case. So thank you very much.
Great case. Difficult even without COVID, even more so with COVID. Thank you, Fiona. Do you want to not share your screen and then we can have maybe Sherry Ann share her screen? And as we make that transition, then I want to introduce Dr. Sherry Ann Nathan. She's the chair of otolaryngology head and neck surgery at the University Health Shreveport and the Overton Brooks Veteran Affairs Medical Center, and is also president of our American Head and Neck Society. Sherry Ann, thank you so much. She will be presenting a case with nodal disease. Sherry Ann, thank you.
Can you all hear me?
Yes.
Okay. So thank you so much, Dr. Randolph, for the kind introduction and the honor and privilege really to be part of this panel with our illustrious British colleagues. So my last international meeting prior to COVID was actually at the Liverpool Northwest Society of Surgeons with their president, Lena Chagla, and I gave a lecture sponsored by BAETS and have fond memories of that meeting since it was the last international meeting. So 2020 has been a difficult year for all, especially for those who've lost loved ones. But I think a silver lining has been the growth in our educational opportunities that have blossomed through these virtual conferences. The endocrine section of the AHNS under the leadership of Dr. Randolph and Dr. Stack have been right in keeping with the energy our thyroid provides. Here you see our Energizer bunnies, and a shout out to Betty as well. So they've provided exchange of information and ideas, not only to our members and international colleagues, but to patients through Twitter. And so thank you for all you do. So moving on to the case, I want to give a shout out to Dr. Horwick, our head and neck fellow, who helped me put this together. So we have here a 49-year-old female who was referred to us from primary care for a palpable right neck mass that she said had been present for a year. And her only symptoms really that she was concerned with were cosmetic. She actually denied any other head and neck symptoms. There was no dysphagia or dynophagia or talgia, no voice changes, or any symptoms of hyper or hypothyroidism. Now, she was a non-smoker and no family history of thyroid cancer or previous irradiation. On physical exam, all she had was a 3-centimeter level 3, pretty mobile right lateral neck mass. We scoped her for looking for any head and neck primaries, and there were none, and also her vocal cords were mobile. Now, as she was referred to us, she had come in with a CT scan, and interestingly on that report, they favored right branchial cleft cyst. So here's just one of the images of the right neck mass. And then on the right, you see the thyroid. And I'm going to start with Dr. Stack. So Brendan, can you tell me, based on the CT scan, what would your differential diagnosis be?
Well, certainly a branchial cleft cyst would be in the differential. And I would think of that if I was seeing someone in their late teens or early 20s, probably ahead of metastatic thyroid cancer. But someone coming in their late 40s, and a female in particular, that probably would not be on the top of my list. And I would be worried that they have a malignancy. Now, my first thought would be, especially if they didn't have head and neck cancer risk factors, that it would be a metastatic thyroid malignancy. And even though the thyroid is unremarkable on the CT, you can have clinically positive adenopathy generated from a microcarcinoma, which might not be detected by a CT contrasted or non-contrasted of the thyroid.
Thank you. So absolutely. And so in the differential diagnosis, like Dr. Stack said, branchial cleft cyst was a little lower down, especially looking at that CT scan, and thyroid metastasis. But given also the epidemic we see of HPV-associated head and neck cancers presenting with cystic neck masses, the P16 head and neck cancer, unknown primary 2, was very high up on the differential. So moving on, Dr. Scott Coombs, how would you work up the patient at this point?
So I think well, first of all, looking at that CT scan of the thyroid, all I could see was a white out of contrast. And I think CT is not a very good way of looking for thyroid malignancy at the primary per se. So I'd be interested to know what an ultrasound scan was showing of the neck in general. And I'm not an ENT surgeon, but if one was considering the possibility of SCC, then I presume one would be thinking about panendoscopies, etc. If the patient came to me, I would do a biopsy, fine needle aspirate of the cystic lesion, and we've had quite a lot of success of sending the sample not only for cytology, but sending some off to the biochemistry laboratory to assay for thyroglobulin, which has been extremely useful. I can think of 3 cases where we've diagnosed papillary thyroid cancer just on the basis of a very high thyroglobulin, even as when Dr. Stack says you can have a very small primary tumor of the thyroid.
Thank you so much. So that's exactly, what we did. So the patient underwent a fine needle aspiration biopsy in clinic, which was initially non-diagnostic, and then an image-guided FNA, which was still non-diagnostic, and it was sent off for a thyroglobulin rinse, and that resulted in a value of 10,000 nanograms per ml. So that really clinched the diagnosis here. And so, Dr. Stack, what would your next step be?
Well, I think Dr. Scott Combs pointed out the poor quality of thyroid imaging based on CT. So somewhere along the way, whether it was part of obtaining the aspirate or separate from that, I would get a good thyroid ultrasound and I'd look at the rest of the neck by ultrasound so that I could get an appreciation in a more global sense of what's going on. Right now, with the data we have, we know that the patient is likely going to need a total thyroidectomy and some type of neck dissection on the right. And the ultrasound would help give us a little more detail as to the extent of the surgery the patient would need.
So that's exactly what we did. So an ultrasound of thyroid and central neck was performed. And you can see here a 2 by 1 centimeter right inferior thyroid nodule and no suspicious nodes in level 6.
May I ask a question? If you have imaging, say CAT scan, and the central neck is completely negative, would you perform a central neck dissection? The disease in the lateral neck must have potentially traversed the central neck, but if the central neck is negative, would you perform what is then a prophylactic central neck dissection in this setting? Brendan and David, can I get your opinions?
Absolutely, I would.
Yeah, and me, but our experience mirrors, I think, the literature, which is that both ultrasound and CT are unreliable in staging level 6. So it would be a decision, well, in the presence of the gross lateral dissection, yes, I would do a central nodal dissection, but you'll only really know about whether there's a macroscopic disease often and at the time of your operation.
Absolutely. And another thing to think of is that if the lesion was on the superior thyroid, it's possible that it had straight metastasis to levels 3 and level 4. But if it involves any other part of the thyroid, as Dr. Randolph mentioned, it's going to go through level 6 before it presents and is clinically obvious in the lateral neck. So I think the level 6 needs to be resected as well.
Right. So the patient was consented for a right selective neck dissection, levels 2 to 5, and then bilateral level 6, and a total thyroidectomy. So, interesting question that Dr. Randolph posed about the central neck. And I think, yes, we would all probably definitely dissect the right level 6. However, at the time of the dissection, one, there were no obvious masses in the thyroid. The right level 6, no nodes, no obvious nodes were noted. And so I'd just be interested in, your input on who would then dissect the left level 6. I'll start with Dr. Randolph, because we elected not to, given there were no nodes that were visualized. Dr. Randolph.
I thank you so much. So actually, Quinn Dunlap is asking exactly the same question. So it's a very good, the audience is interested in this. I'm a believer that, gross nodal disease should be removed and microscopic or negative nodes should not be removed. So, and I'm also doing this long enough to know that a bilateral paratracheal dissection is a potentially harmful procedure, even in skilled hands. So I would de-emphasize the contralateral obligatory prophylactic paratracheal dissection in this setting for sure. That's my own opinion. But Brendan and David and Neil, what do you think?
Amen.
Yep.
Yeah, I agree. I mean, it's interesting. We all sit here at the moment in our armchairs discussing these things, but we know that sometimes, it's such a variable spectrum of disease. You can have really, really gross nodal disease, and you can have absolutely nothing. And you can be dissecting air, one oncological benefit you're bringing. So I think it's a nuanced decision to each case at the time of surgery, but being cognizant, as Dr. Randolph says, about the morbidity, particularly to the parathyroids.
But this is an important point that Sherry brings up, because in the past it was central neck dissection or not. And now it's understanding that there are separate pieces to that question, especially as it relates to morbidity. So there is an independence of the left and right paratracheal nodes. You're allowed to delete one if you feel that's in the best interest of the patient. It's a very important, nuanced understanding to central neck dissection. It's a good point, Sherry Ann.
So, the other question I want to pose for the panel is level 2, right? Who would dissect level 2B if your level 2A showed no obvious nodes? I'll start with Brendan.
So my philosophy with 2B is if 2A was grossly involved, I would go to 2B. But I think there is some potential harm in routinely manipulating the 11th nerve in all cases. So I would just do 2A and stop there if it was not grossly involved.
Dr. Scott Coombs, what about you?
I completely agree. But I think you've got a real handle on what you're going to be doing, because with the right ultrasonographer, I think you've got very accurate preoperative notion of what nodes are going to be involved.
Yeah, and I think the other important thing is if it's a superior pole malignancy, then there's a higher chance of level 2, like Brendan said, and maybe at that point there's a more of an indication to dissect level 2B. So anyway, our pathology showed a right lobe with only a 1 millimeter focus of micropapillary. The nodule seen on ultrasound was benign, and the left lobe also showed a 9 millimeter focus of micropapillary carcinoma. There were 2 of the 57 nodes were positive, one at level 3 and a smaller one at level 4. And level 6 on that right side, none of the nodes were positive. So this patient was staged as T1A, N1B, M0 papillary thyroid cancer. So just moving on, since the topic is bulky nodal disease, I think we all know that the ATA guidelines recommend a comprehensive neck dissection. Berry picking is definitely not indicated or recommended, and we've discussed what levels. Level 2B is still relatively controversial, but still routinely addressed. And so I think, just in terms of spinal accessory nerve, here you see a picture of the nerve. 96% of the time it's lateral to the IJ vein, only 3% medial and 1%, through the vein. There's certain tricks to finding that nerve. You skeletonize your digastric, your SCM, and as you roll the fascia of that SCM, most often your patient's obviously not paralyzed, is being monitored, you start to see that shoulder jump and you have an idea of where that nerve. Your retractor halfway between the anterior and posterior width of the SCM, you can almost palpate it as a cord-like structure prior to being seen. The other areas to be concerned about when dissecting is, a really good level 4 and 5 dissection. On the left side, one does need to be careful about the thoracic duct. It terminates around 1 centimeter around the IJ vein. And here in this paper, you can see 46% of the time into the IJ, 18% into the subclavian, and about 32% of the time into the junction. So identification and preservation is ideal, and meticulous low-level 4 or 5 lymphatic tissue in papillary thyroid really needs to be performed, and probably safer with bipolar because of these lymphatics. So I want to end with just, a paper on diagnostic values of thyroglobulin in these lymph node fine needle aspiration washout. Although the ATA guidelines really don't recommend that as yet because there was weak evidence, I want to point out this more recent paper, which was a systematic review and meta-analysis of FNA thyroglobulins. And this was a literature review between 1993 and 2017. And there were 22 studies, and they looked at about 2,670 lymph nodes, mix of solid and cystic. And interestingly, there's always this question, what's your highest sensitivity and specificity? So 1 nanogram and above detected papillary thyroid cancer in the lymph nodes, the overall sensitivity being 0.91. And the value for the highest specificity they noted was around 40 nanograms per ml. So the overall specificity being 0.94. So I think, hopefully in the next few guidelines, that may be a change, especially plays a role in these cystic nodules or cystic nodes. And I think there's controversy in the presence of thyroglobulin antibodies. What's the role in the presence of the thyroid still being there, especially for level 6? How does that play a role? And I think there's a number of interesting papers out there, which there's no time to discuss. But thank you very much for the opportunity. I don't know if there's any other.
Sherry, can I just ask a question on behalf of some of our attendees? Level 5 has come up as a topic of conversation. In the absence of any nodes on ultrasonography, do you routinely clear level 5, and what levels do you do?
Was that to me, the question?
Yes.
Yes. So I think level 5B should routinely be done in a lateral neck that has nodes. And in this patient, there was a node found at level 4 on the final path. But yes, I would recommend routine dissection of level 5B for these bulky nodes.
If I may interject, I think the discussion of doing level 5B is like doing 2B when 2A is positive. If 4 is positive, you should be thinking about doing 5B.
We might want to move on to our next case here. We can probably go about 5 or 10 minutes beyond our time since we went over.
We started 10 minutes late.
We started a little late. So Fausto O'Neill, maybe you would introduce our great friend Fausto.
Oh, I'm delighted to introduce him. So Fausto Palazzo is my colleague and a best friend. He's from a general surgical background, so it just shows that otolaryngologists and general surgeons can work productively together. We are part of the same team. And I've had a very fruitful working relationship with Fausto for over 10 years now. We both work at the Hammersmith Hospital, which is part of the Imperial College NHS Trust. Fausto's had extensive training in endocrine neck surgery. He's done fellowships in Marseille and also in Sydney. And I'm delighted to introduce him to our webinar to discuss the case of reoperative parathyroidectomy. Fausto, thank you.
Okay, thank you very much, Neil, for the introduction. I should point out that this case I'm about to present to you is actually one of yours. So I don't say that to distance myself from any of the decision making that may have occurred during this operation, but mainly so that in the event that I'm unable to answer the questions, you'll be able to chip in and add your opinion. So I have no conflicts of interest, which was that slide there. So this is the case of an 84-year-old retired headmaster with no significant past medical history. He has a diet, tablet-controlled hypertensive, but relevant to this case, he had a parathyroidectomy in the 1970s when he was in his early 30s. And he was cured by this operation. And we know that because we have a knowledge of him being normocalcemic. But it should be pointed out that the operation was so long ago that we don't have access to his histology. But what we do know from the patient's history is that his presentation in the 1970s was with a myopathy. This man has no other endocrinopathy and has no family history of endocrine pathology. He was admitted to a local hospital in April of 2020. So here we are once again presenting a case of a patient with a problem in the middle of the COVID crisis in the UK and the lockdown. This has a great impact on this case. And he presented to hospital with 3 months of extreme muscle weakness. He was dehydrated and confused. And his biochemistry what was quite marked in that his serum calcium was 3.69. So for the Americans, our normal range in millimoles per litre is 2.1 to 2.6. And the parathyroid hormone, the normal range is up to 7. So just to give you an idea, the calcium is very significantly raised and the parathyroid hormone level is something like 5 times above what we would normally expect. The patient was vitamin D replete and the urine calcium unequivocally confirmed the diagnosis of a recurrence of his primary hyperparathyroidism. So this patient was managed by the physicians in a local hospital and they treated him medically with hydration and cinacalcet, or you may know it better as Mimpara, a calcium mimetic in other words. So we've got a patient here of 84 years, reasonably fit and well, and with a recurrent hyperparathyroidism in a local hospital. So at this point, Neil is having to meditate a little bit, as you can see here, as to what do we do next. So I don't know if the discussants want to give us an opinion on what they've heard so far.
Well, first, I was actually reading the joint American Head and Neck Society and BAETS guidelines on revision parathyroid surgery.
So thank you. Fantastic. If I could just say a couple of comments. I mean, we presume abnormal parathyroid tissue was removed at the first attempt. So one would be thinking that this man has multiple gland disease. He has to have. But the best series that I've found from Uppsala in Sweden, which followed up patients for had 2 patients who developed a second adenoma, one at something like 7 years and one at something like 14 years. So it's not inevitable that he's got foregland disease, but he's definitely got recurrent disease. And if he doesn't respond to the medical treatment, you're going to be thinking about surgery.
I totally agree with David. I mean, I think this is eventually going to end up in surgery or some type of palliative medical treatment. But I guess during a pandemic, I would try to leverage my medical management the best I could. But obviously, has his myopathy returned? What's his quality of life? How's his function? This may force us to surgery even during a pandemic.
Okay.
Could I just add a few more clinical details about this patient? So this patient cognitively was very well. He was mobile 6 months prior to being admitted with severe dehydration and cognitive change. And although the calcium came down on rehydration and cinacalcet, the myopathy was still profound. We just couldn't get him out of bed. So he was bedbound essentially, and that was the clinical situation presented to me in the middle of this pandemic, where once again there were no ITU beds, and even doing any form of elective surgery was extremely difficult.
no one's commented on the fact, David, you've commented on the fact that this man clearly has multiple gland disease of some sort. His first parathyroidectomy, he was very young. Now, in the 1970s, they didn't have the option of MEN1 screening, but in your practice, if you have a patient of 30 years, so the diagnosis, let's say, is at 30 years, so presumably he had the disease in his 20s, at what point do you routinely do MEN1 screening in your service?
Well, I don't have a choice because our endocrinologists do it, and they will screen anyone under the age of 40 for genetic disease. But you know that Marseille looked at this with a huge series of patients defined as young, being 40 or less, and there were no surprises. That is to say, those patients who had multiple gland disease at surgery had a genetic abnormality, and those who had solitary disease didn't. So he was young, but he was 30, and we see a lot of patients with sporadic disease at that age. So it's by no means inevitable that he's got genetic disease, and of course there was no family history.
But Fausto, you're implying now that he has demonstrated he is a multi-gland disease and presented at a younger age, the index of suspicion now is quite high.
Yeah, I think that he's 84 years of age and he doesn't have any of the other associated endocrinopathies of MEN1 syndrome, which would be what we're thinking of. So the chance of him having MEN1 is probably quite low. But I think what's of more relevance and interest is, it's academic, you might say, is whether today a 30-year-old gets an MEN1 screen. And in our service, we're in the same position as David Scott Coombs in Cardiff, namely everybody under the age of 40 years of age gets an MEN1 screen. And I have to say that the rationale for this is, in my view, is correct. And that's that you can, if you know that the patient is MEN1 positive, and actually our yield in patients under the age of 30 is quite high, these patients, you can tailor their operations much better, rather than having a post-operative diagnosis of MEN1, where the things get a little bit messy. Whereas if you know a priori that the patient's MEN1 positive, then you can decide how to approach the problem and ideally do a subtotal operation. But that's taking a sort of a slight tangent, because it does mean another discussion altogether. But that's just an interesting point in this man. So we'll move on now to the investigations. Now, the gentleman had an ultrasound scan of the neck, which was negative, and we were unable to get a sestamibi scan because of the COVID-19 crisis. And it's a bizarre thing, because during COVID-19 lockdown and the crisis in the hospitals, some scans you could get and some scans you simply couldn't get. And I imagine a sestamibi scan was not available because it was considered a benign pathology. Whereas because choline PETs are used in prostate cancer, it's possible that the choline PETs were still going. And so the choline PET was available to Neil, and so the choline PET was arranged. Can I just one very briefly, Brendan, in the US, is choline PET scanning being used exclusively in re-interventions, or have we had the usual drift when a new bit of technology comes out where patients are getting choline PETs in virgin necks? Dr. Stack.
I think Brendan has fallen off here.
Yeah.
He's lost his internet, but I'll just pipe in that many centers do not have choline PET available. And so I would say that it is quite preliminary and quite sporadic, and would be, when used, typically applied to more revision settings. It would not be first line imaging recommendations pretty much anywhere in the US.
Okay, thank you.
So just to go back to basics, obviously this patient has to be localized preoperatively, unlike a virgin neck. What about 4D-CT, Fausto? Is the Hammersmith too advanced for that?
We do like a 4D-CT, and in re-interventions, 4D-CT is the other option. But I think that we, generally speaking, tailor the modality to a sixth sense about what we're likely to be dealing with. So there's no science to this, but we sometimes use 4D-CT and other times use choline PET.
I would just weigh in that in the US, 4D CT scan, unlike PET choline, has really taken off. And for example, I use ultrasound and 4D CT scan on all first-time paras.
Perhaps I can
It's like CT scanning in terms of nodal assessment for papillocarcinoma. You can get addicted to that. When you find the thing that's ectopic and you know exactly where to go. So 4D CT scan has really taken off in the US.
Yeah. Okay. I'll move on. And these are the images. So I don't know if this is going to work with my cursor, but you don't need to be a nuclear medicine to spot two abnormalities here in this patient. So I should point out this man had a classic 84-year-old man's neck. So he's kyphotic, very limited neck extension, and the inferior aspect of thyroid basically sitting at the thoracic inlet. And so you have two hotspots. This larger hotspot more laterally, and then a more medially, still on the right side, was a second hotspot. And here on the CT component of the choline PET, you can see what has been identified. So at this point, after a bit of meditating, as you saw in the photograph earlier, Neil decided quite rightly that he had the indications of surgery because medical management was not working. They could not get him out of hospital, and without a lot of fluids and cinecalcit, his calcium could be controlled, and he had the ongoing myopathy. So the patient then was considered for surgery. Now, there are some considerations here before taking a man such as this to surgery. Well, first of all, he's had a previous neck surgery, but at this point, we were not able to do laryngoscopies because it was considered an aerosol generating procedure. So we didn't have information on this man's vocal cords, although his voice was normal. Obviously, re-intervention mandates nerve monitoring. Now, whatever you may say about nerve monitoring in parathyroid surgery, some people feel that the incidence of nerve injury is too low to justify the cost, but we use it routinely. But nevertheless, in reoperative surgery, it's absolutely beyond discussion, I believe. Intraoperative PTH is of great value in re-intervention. Again, this is an opinion, but I think it's easy to justify. And of course, if you are going to have the possibility of needing access to the chest, you need to consider either a cardiothoracic backup if you don't do it routinely yourself. So all these things were put in place.
So may I just mention that Mary Siebelik, one of our renowned American surgeons, has mentioned ultrasound can be utilized for vocal cord evaluation preoperatively. That may not be efficacious in this 84-year-old who likely has calcified thyroid cartilage, which you could not see through, but that's a very good point. I would just say that it's true vocal cord examination is an aerosolized generating procedure, or can be when it's not tolerated well, but so is intubation for this patient's surgery. So here, the decision would be he needs surgery, he needs COVID testing. COVID testing negative means he can get a fiber optic exam and intubation for surgery.
Yeah, those points, all those points are well taken. And of course, in the CT component of the choline PET, you can look at the symmetry of the vocal cords as well, which can be useful.
But Fausto, I would agree with all of that, but do you really need a cardiac surgeon for a tumor that's sitting at the tip of the at the top of the thymus?
That's a good question, but I think you need to look at the context, which we'll discuss now. So
I would just say for when I counsel my otolaryngology fellow, I say the problem with that midline lesion is not how deep it is, that is how caudal towards the feet, but how ventral it is and has to be peeled off the back of the sternum, because typically they're looking down. And so I think if anybody has any question about cardiothoracic backup, it's good to have it available, just to be on the safe side. Would you really need it? Probably not, but.
I entirely agree. And I think that one of the lessons in life is if you don't plan for it, then you need it. So I think we're blessed at the Hammersmith with having a whole army of cardiothoracic surgeons. And as you know, cardiothoracic surgeons are not as busy as they once were. So they come running with enthusiasm. So the old scar was excised, and a lateral approach, our standard approach for re-intervention, was adopted from the right side. Now, this man had very limited neck extension. So just to make this quite clear, to the extent that you couldn't see the thymus. Yeah. Now, in an inferior the second gland, which is an inferior gland, given that a large right descended superior parathyroid gland was removed, the second gland was not accessible via a cervicotomy alone due to body habitus, limited neck extension, thyroid essentially sitting at the thoracic inlet, and thymus, which was not accessible. So this is what happened to the numbers intraoperatively. I repeat that the normal range of PTH in picomoles per litre is up to 7. So the baseline PTH was 113. After a bit of manipulation of the big descended superior parathyroid gland, the PTH went up briskly, and at 5 minutes, it was 170, and at 10 minutes, it was 80.
And Fausto, that 3.4 gram, that is the lateral nuclear
Correct.
medicine finding. Is that correct?
That is correct. It's this one.
Mm-hmm.
Okay, so that was removed. So Brendan, I'm assuming actually Brendan's not available. David is a great intraoperative PTH aficionado and has published very widely on this. So
back on, Fausto.
Brendan. So, Dr. Stack, do you want to tell us what your feelings are about what criteria you use in intraoperative PTH?
So, obviously, your scale of numbers are a little different than mine, and so I'll revert back to what I would normally think of, which is a normal is 12 to 88. And what I would like to see is basically a modified Miami criteria, which is a 50% drop into the normal range for your laboratory. But even saying that, that would be with a high number starting like this, would be under 88. I wouldn't feel good about that. In my laboratory, I would prefer to see something like 30 or 40 at the most. And so the first thing I would do is check a 15 and 20 minute to see if the trajectory was continuing downward.
Okay, so in other words, if I may, you don't use the pure Miami criterion. So the pure Miami criterion was a 50% drop from the peak and not necessarily within the normal range. Others have added, Bruno Niederle in Vienna calls it the Vienna criteria, that in Rocco Bellantone in Rome calls it the Rome criterion, where basically they say you've got to have a 50% drop and it's got to go into the normal range. So you use, let's say, a modified Miami criteria. Is that right?
Yes.
Okay. David?
Yes, that's correct.
So we use the Miami criteria of the purest form, which is that if you get more than a 50% drop at the highest pre-excision value. So here, the peak was 545. So anything less than 222.5 would be, 272.5 would be sufficient. And we have performed operations where actually the final PTH has been higher than the starting PTH, which is disconcerting. If at the end of this you're going to tell us that the patient is hypercalcemic, then this would be a false positive drop. And our false positive rate is just about 1%. So it's extremely unusual. So if we weren't knowing that we had 2 lesions on the scan, I'd be pretty chuffed that having removed that tumor, we had done a satisfactory operation 99% of the time.
But Fausto, I don't understand why you're checking these levels in the first place, because you haven't found the second targetable lesion yet. So structurally, surgically, you're not even complete with the surgery.
Well, the issue here is that faced with a lack of access to the second parathyroid, the question is, do you use intraoperative PTH to guide your next move? So if we listen to David Scott Coombs, I'm assuming, in fairness, I'm assuming David would not refer in this specific case because there's a second hotspot. The second hotspot means you know there's something else going on, very, very probably. But the question is, in an 84-year-old man, you've taken out a big adenoma, the intraoperative PTH has fallen pretty convincingly using the conventional, most basic, pure criteria, as to use David's expression. The question is, what happens next? Do you continue taking more samples, as Dr. Stack recommends, or do you say, right, I've got to, and if it doesn't drop, presumably, you have to then open
I would just say, as a purist, though, that you're using biochemical parameters in the setting of other targetable information, and that isn't legit. In other words, the IPTH is done in assuming that there is no targetable information still available. So I think you need to incorporate that imaging information. You can't just use IPTH. You have another lesion there. Yes, David.
Well, this is a great case because that second lesion cannot be accessed without a major intervention surgically, because if Fausto can't get to the thymus, then none of us will be able to get to the thymus. So and we don't actually know for certain that this is another parathyroid, but it's likely to be. But you can get other funny things in the thymus. So I personally, in this setting, would now stop. We know we've successfully removed a large parathyroid. You knew that before the intraoperative PTH. But interestingly, the Miami criteria suggests that you might actually have done enough. And I think it would be unnecessary and I would say probably unwise in a COVID era to start thinking about exploring the mediastinum in other ways. I would stop, see what the calcium is post-operatively. If you were to do what Brendan normally does, which is carry on measuring until the PTH goes into the normal range. Well, if it never does, I wouldn't change my view then. So I would stop now.
Fausto, there's a comment from Radu Mihai in Oxford, who feels could you ignore the second lesion inside, wake the patient up, then review the biochemistry, and if needed, then do VATS rather than the sternotomy at a later date in someone of this age? Would that be a better?
I think that's reasonable. I mean, I would say that this. I'm speaking on your behalf. This is your case, but I think that the reality.
Yes, whatever you want to.
No. The reality is that I'm really pleased that you're all right. Everybody that's spoken is right here, because this is the nuance of this surgery, because this is a man who, with a sternotomy at the age of 84, would have to go to an HDU, high dependency unit, or an ITU, which was full of COVID. So I think that the decision to not perform a sternotomy in this man, given that the intraoperative PTH showed that you'd probably removed the dominant gland. So I think that therefore Radu's opinion is also correct. Why not live to fight another day? You've done some good. and let's see what happens next in this 84-year-old man.
There's one other comment from the chat about, I don't know if any of you have had experiences with cardiothoracic surgeons when they come in, before they consider open sternotomy, they put in these medieval contraptions that basically lift the patient up off the bed through sternal retraction. And you can get another few centimeters down there, potentially that way. I've certainly removed some things without sternotomy that I was not able to remove through my initial neck exposure with these medieval torture devices inserted. So that's another option. You have to be cautious though, because if the retractor crushes that adenoma into the dorsal surface of the sternum through its insertion, then you've not helped very much. But.
So here, for everyone to see clearly, this man post-operatively is now still borderline calcemic, but this calcemia is off synocalcet. So you can see that he's had a significant improvement in his calcemia, and his PTH is still markedly raised. But what's interesting about this patient is that despite not being cured, he's had a remarkable reversal of his myopathy, much in the same way as he did when he had his original surgery in the 1970s. So does anybody want to have any experience of myopathy in patients with severe primary hyperparathyroidism?
I've only seen it once, and it's a great case, and you know, you've lived to fight another day. The other thing is, of course, he should have 4 glands. One was removed when he was 30. You've got radiological evidence of 2 others, and you remove 1. But where's the 4th? What I don't know, Fausto, and I'm sure you do because you knew what you were presenting, what is the ability in terms of accuracy of choline PET to identify multiple gland disease?
Well, that's a very good question. Most of the time, choline PET is effective. In our series, it's been shown to, first of all, it's not the golden silver bullet that everybody was hoping for. So that's the first thing to remember. The second thing is the vast majority, in fact, I would say all, with the exception of this case, of our patients who have been re-imaged with choline PET have a single focus of disease, and all the ones we've operated on have been cured. So it selects out those with the disease. The only risk of a choline PET is a false positive. But if at the time of surgery, if you've got a hot spot, you remove it and it's parathyroid tissue, they're cured. So I don't know how often and how good it is at seeing multiple gland disease. It is fantastic in identifying ectopic disease, almost to the point where you wonder that of course we haven't had an opportunity to look at the histological makeup and the difference of the specimens, but it's incredibly good at identifying parathyroids in the aortopulmonary window. They light up like a Christmas tree, and the ectopics light up very strongly. But multiple gland disease, I'm afraid I'm unable to answer that with conviction.
Because this man has got to 84, he must have 4 large glands. And so if you are going to reoperate, are you going to re-image him because it may be that the 4th gland will now light up?
Of course, that's a possibility. Of course. And remember, we haven't
how did he do? And he maintained his improvement?
I'll need to answer this. He's much better. He's out of bed now. Unfortunately, because of COVID, he can't do the Boston Marathon. He thinks I'm a fantastic doctor, Professor Randolph. And he's obviously well. He's not cured of his pathology, of course, but I think at the moment this needs to be just managed conservatively, and I don't think there are any indications now for further surgery.
So this is the last slide. There are a few learning points here. The first two learning points are related to the issue of primary hyperparathyroidism and myopathy. Now, it's not very well understood, but it's well documented. We don't know why people get it, except that the associated pathologies of hypomagnesemia and hypophosphatemia are known to be associated with myopathy. So it may be that that's the reason the patients get the myopathy rather than the high PTH and high calcium. All the other learning points are to be found within the joint guidance document, which was published about 2 years ago between our two associations. And the principles are, as we know, that reoperative parathyroid surgery comes with a higher threshold. It's absolutely essential to understand what's happened previously so you can plan your surgery. Imaging is absolutely essential. Without a target, you should not intervene. What imaging you use, well, we've been through some of that. The role of nerve monitoring in re-intervention we've discussed, and equally the role of intraoperative PTH. So thank you very much for listening.
Very nice, Fausto. Thank you so much. Neil, we have gone a little bit over because we had a little glitch at the beginning there. Neil, do you want to make any summating comments there?
Well, I think it's been a very successful first joint webinar between our associations, Greg. I think we've had a good attendance, and hopefully the feedback from them will also be good. And it's certainly something that I'm sure we'd all like to progress and do more of in the future. I'd like to thank Fiona and Fausto for representing the BAETS so well. I think they did fantastic presentations. And thank you for everyone for attending and offering stimulating questions.
Well, I want to join with Neil in thanking Fiona and Fausto and Sherry Ann for their time in presenting, and thank David Scott Coombs and Brendan Stack for their delivering the reality, the actual information, their opinion and judgment as to what's the right answer. And also thank very much Betty for her assistance in doing this. We would not be here if it was not for Betty. So I think with that, we want to now wish everyone a tremendously happy and safe holiday. And I think everyone can join me in kissing 2020 goodbye. I think everyone is ready for that. We're happy to let it go and wish the best for all of our Head and Neck Society members and British Association members, the very best for a happy and healthy 2021. And very much I would look forward to working with Neil towards additional programming where we can all get together, because we enjoy your company and we enjoy learning from you very much on both sides of the Atlantic. So with that, I think we'll close out. Betty, anything else that we need to address?
No, we have covered everything. Thank you.
Okay, thank you, ladies and gentlemen. Thank you. Have a great day and a happy holiday season. Thank you.
Bye.